Good afternoon and welcome to OC Talk, the show dedicated to helping home health and hospice providers keep up to date on the documentation, diagnosis coding, OASIS, and HOPE assessment data collection issues that matter most in home health and hospice. OC Talk aims to bring you closer to reliable experts in home health and hospice and to share the latest news and information from the industry and from the Association of Home Care Coding and Compliance. I'm Jan Milliman, Director for OC, and I'm happy to be hosting today's program. And this afternoon, we're talking about the most recent CMS OASIS Q&As. And now I'd like to introduce our industry guests for this episode. Today we have OC Advisory Board member Lisa McClemmy with us. Thanks for joining us today, Lisa.
Thanks so much, Jan. I'm happy to bring this OASIS Q&A update to everybody. We'll just jump right in. There's about 10 questions, so we'll just get started. Go to the next slide. Okay, so those of you that are not familiar with the Q&As, if you don't keep up with them, you can get these on iKeys. They update every quarter, and this is the July 2025 ones. Again, there's about 10 questions this time. Sometimes there's less, sometimes there's more, it just depends. But we're going to go through each question, and then at the end, I've got a section on skilled needs. So if you have questions as we're going through the first few, I may answer those towards the end when we talk about the skilled needs. So first question, does the OASIS data need to be collected and submitted for Medicare Part B outpatient therapy patients that are being seen by a home health agency? So we're still having a lot of questions surrounding who do I have to collect OASIS data on? And the answer to this one is, if that Medicare beneficiary receives skilled outpatient therapy service from an approved Medicare certified home health agency that's billed as outpatient services, you do have to do OASIS collection and submission for that patient. So, and just to reiterate here, and they're just reiterating it in the answer, OASIS data collection and submission is required for all patients over the age of 18, regardless of the payer, unless they're receiving only maternity services or only personal care, chore, or housekeeping services. Now, these Q&As don't address billing, so they go on at the last sentence here in this answer to say any questions about billing outpatient therapy services, you need to direct those to your MAC. But as far as OASIS collection and submission, the answer is yes, if they're getting skilled services. Okay, next slide. Question 2, if none of the services a patient's payer authorizes, and the examples they give are long-term medication management, flushes, simple dressing changes, those types of things, if they're not considered skilled under the Medicare home health benefit, would OASIS data collection and submission be required? And the answer is no. If none of the services provided meet the definition as defined in Chapter 7 of the Medicare Benefit Policy Manual, then you do not have to collect and submit OASIS. But if any of the services do meet that definition of skilled services, assuming the patient doesn't meet one of the other exemptions, then you would have to collect OASIS. So again, no skilled service, you don't have to, but if they meet any of those skilled services, and again, we're going to talk about skilled service at the end. I've got, I think, 4 slides on that. So next slide. So for question 3, we received a referral for occupational therapy only for a patient with private non-Medicare insurance. The private insurance will pay for home health in this instance, although since this patient does not have nursing, speech, or physical therapy, they would not be eligible for the home health benefit under Medicare. So what they're asking here is, I mean, setting the stage, the payer doesn't matter, and we'll talk about that when we get to the answer, but this payer covers OT alone, where the Medicare home health benefit would not. So they're trying to ask the question here, since this patient is not eligible for the Medicare home health benefit because it's only OT, even though their payer covers it, is OASIS data collection and submission required for this patient? Next slide, Jan. And the answer is yes, it absolutely is required, because when you're, this patient is over the age of 18, and regardless of the payer, if they're getting skilled services and not only receiving maternity or chore or housekeeping services, then you have to collect the OASIS and submit the OASIS data. Now, again, they're saying this in a couple of different ways in this answer, but skilled care is the part that decides whether you do the OASIS data collection or not. Whether they meet the home health benefit for Medicare, that doesn't matter. You're talking about, are you giving this patient skilled care? Are you a Medicare certified home health agency? And if the answer is yes, then you have to collect OASIS data no matter who the payer is. So again, just they're saying it a few different ways here. Just remember, if you're providing skilled care and you're a Medicare certified home health agency, you need to be collecting OASIS data and submitting it unless the patient meets one of those other exemptions of being under the age of 18, maternity services only, or only personal care, chore, or housekeeping services. Okay, again, we get lots of questions still about that. Question 4. We understand that Medicare does not require a new start of care when a patient's payer changes from original or traditional Medicare fee-for-service to a Medicare Advantage. So it's not required. And they tell you here that that's per the Claims Processing Manual, Chapter 10, Section 10.1.23. However, for various reasons, and part of those have to do with EMRs a lot of the time, some home health agencies choose to document all changes in payer source according to that requirement. So what they're saying here is they, a lot of agencies, regardless of whether they're going from traditional Medicare to Medicare Advantage or vice versa, or to a different insurance, they elect or decide that they want to do a new start of care. So in the April 2025 quarterly Q&As, one of them was, if continued OT is the only active service at the time of a pay source change from a Medicare Advantage to traditional Medicare, Medicare fee-for-service, the OT can complete that start of care OASIS and continue to provide care as the only active discipline for the remainder of the home health stay. So at start of care, under the Medicare home health benefit, OT cannot establish eligibility, but in the case where the patient's been on service and they're changing from a Medicare Advantage to traditional Medicare, OT can be the only service. They can do the start of care because they've been insured by Medicare, if you will, through a Medicare Advantage. So it's not like they're starting Medicare initially when you're doing that start of care. So the question now is, for home health agencies whose policy is to complete a new start of care when the pay source changes from original Medicare to Medicare Advantage plan, does this new guidance regarding the continued OT completing the start of care also apply? Next slide, Jan. And the answer is yes. So if a patient transitions from original or traditional Medicare fee-for-service to Medicare Advantage plan while a home health patient, then the new start of care assessment is not required. But if the agency chooses to complete that new start of care assessment, when the patient has that payment source change, then continuing OT, sorry, get my words mixed up here, is the only active service remaining at the time of the pay source change. The OT absolutely can complete that start of care OASIS and continue to provide care as the only active discipline. So there's nothing different when you're going from Medicare Advantage to traditional or vice versa. The OT can continue as the only service and they can do the start of care OASIS assessment. So next slide, Jan. So there's several things around a Medicare Advantage that you need to know. And I thought these were extremely important to point out. So Medicare Advantage plans are required to cover home health care services at the same level as original Medicare. The differences you need to be aware of are, number one, Medicare Advantage enrollees may need to use an agency that's in network for that specific Medicare Advantage plan. Number two, some plans may require prior authorization or referral form from the patient's doctor before they can get those home health services. And number three, while original Medicare fully covers home health services, Medicare Advantage plans may charge copayments, deductibles, or coinsurance. We kind of all know those. Next slide, Jan. The one that you want to make sure you understand is CMS regulations at 42 CFR 422.112B8 provide important continuity of care protections to ensure that patients newly enrolled in Medicare Advantage plans can maintain their existing care arrangements during the initial transition period. Medicare Advantage plans must provide a minimum 90-day transition period for any active courses of treatment when an enrollee in a Medicare Advantage plan has enrolled in a Medicare Advantage plan after starting a course of treatment, even if the service is furnished by an out-of-network provider. This enrollees new to a plan and enrollees new to Medicare. The Medicare Advantage plan must not disrupt or require reauthorization for an active course of treatment for new plan enrollees for a period of at least 90 days. Just some interesting information that you probably want to make sure that you're aware of. All right, Jan, the next slide for question number 5. You notice here we've gone to category 4, the OASIS data set items. And we're going to start with the M1840. So if a patient can physically get to and from the toilet in the bathroom with or without assistance, but experiences incontinence on the way, should the episode of incontinence be considered when coding M1840, toilet transferring? And the answer is, you're assessing, can that patient safely get to and from and transfer on and off the toilet? Their ability, not necessarily their performance, is what you're assessing. So you have to consider the patient holistically. The only time you would consider that incontinence is if it affects their ability to get to and from and transfer on and off the toilet or bedside commode. So, you know, there may be instances where it absolutely affects their ability, but if it does not affect their ability, the fact that they have incontinence getting to and from or on and off the toilet does not affect how you're going to answer that question, unless it affects their ability. All right, next question, Jan, or next slide, Jan. Okay, so this patient, we're talking about the GG. First, they addressed the GG-O110 question. Then they're asking about GG-O170M, N, and O. Patient has stairs and an elevator in their home. Is an elevator considered a mechanical lift for the GG-O110C, the prior device used mechanical lift? Does it count as an assisted device like a stair lift for the STEP questions, the GG-O170M, N, and O? So they always in the answer define what the definition is. So GG-O110, prior device use, identifies patients' use of devices and aids immediately prior to the most recent illness, exacerbation, or injury that initiated this current episode of care. Next slide. So mechanical lift. It includes any device a patient or caregiver requires for lifting or supporting the patient's body weight. And they give some examples, but they don't give an all-inclusive list. So the examples they give are stair lift, Hoyer lift, bathtub lift, sit-to-stand lift, stand assist, electric recliner, and full body style lifts. For the responses in GG-O110, there's not an all-inclusive list or an exhaustive list, so you're going to have to use clinical judgment to determine whether the device meets the definition provided for that one. I think you're going to have to consider, why does the person use the elevator? Do they have the ability? or did they have the ability prior to? Did they use it for convenience? Did they need it? So I think you're just going to have to use your clinical judgment, and each patient's going to be different when you're answering the GGO 110 prior device use. They're very clear, though, when you're talking about the step questions, in that bottom section there, the intent of the 1 step, 4 steps, and 12 steps is to assess that patient's ability to go up and down the steps. You do not consider an elevator as an assisted device for those. So if they don't do the steps and they use an elevator instead, you don't consider the elevator the same as a stair lift, and they're clear about that. All right, next slide. So question 7, when you're coding the GGO 130 self-care and GGO 170 mobility, it's being suggested, and I'm assuming this is from a reviewer or something, that we not code higher than supervision due to the fact that the assessing clinician's there during the assessment and supervising the patient at that time. Is that the correct approach? Next slide. And the answer is no. The fact that you are there assessing them does not necessarily, that it's not automatically providing supervision, the fact that you're assessing them. So the answer to that question is you would be able to score them as independent. You would not only score them as supervision because the clinician's there. That makes absolutely no sense whatsoever. So for GGO 130 and O 170, the assessing clinician would code each activity based on the type and amount of assistance required, and you being there assessing the patient would not necessarily be considered assistance, however much assistance you have to give them. So the answer is no. All right, next slide. So if a patient is a wheelchair user and goes up a ramp, can the ramp be considered when you're coding the stair activities? You do not consider a ramp when you're coding those step activities at all. So that one is pretty straightforward. It's been answered a few times before. So again, you would not consider a ramp in place of the stairs. Next question. When you're talking about KO 520, is a fluid restricted diet considered a therapeutic diet for KO 520? And the answer is it depends on why. So if in this situation, the fluid restriction is prescribed to manage a disease or a clinical condition, then you absolutely would consider that fluid restriction as a therapeutic diet for KO 520D. It's not defined by the content of the diet or of what's provided. It's why that diet is required. That's what decides whether you include it as a therapeutic diet or not. And last question. So when coding the O110 special treatments, procedures, and programs, should a tracheostomy or should tracheostomy care O0110 or O0110E1 tracheostomy care only be checked when the patient still has a tracheostomy tube present, or would it also be checked for patients who have been decannulated with that trach tube removed, but care to the trach or stoma site is still part of the treatment plan? And the answer is if the patient has the trach still, whether it's you have the trach tube in or not, if it's part of their treatment plan, then you absolutely would still code it. All right, next slide. So let's talk about skilled services a little bit. We've still got several minutes that we can talk about this. These slides and the information in them come directly from the Medicare Benefit Policy Manual, Chapter 7. You need to reference this if you have a question about skilled services. But skilled services are defined as services that require the expertise of licensed professionals, RNs, PTs, OTs, SLPs, to maintain or improve the patient's condition or prevent deterioration. Some examples, and I've got several examples here, and these are not all inclusive. There can be others, but wound care requiring sterile technique or complex dressing changes. That would be wound vacs, frequent dressing changes, infected or non-healing wounds. Medication administration or teaching, and that can be any number of medications, but some examples of those: insulin or anticoagulants, monitoring for adverse reactions or effectiveness of new medications, and we'll talk about that in just a minute. IV therapy or injections that require clinical judgment, Another example, oxygen therapy initiation, teaching, and titration. All of these are examples of skilled services. Catheter care requiring skilled oversight. Next slide. Still more examples, monitoring of unstable conditions or potential for exacerbation. So if monitoring, you can do that for 3 weeks as long as the potential for complication or further acute episodes remain. So that if you're monitoring, you can do that for 3 weeks. Teaching disease management, and that's cardiac, pulmonary, diabetes, neurological. There's lots of different things that could fit into those categories. And what you have to remember here when you're talking about teaching anytime, if you keep a patient on for multiple certification periods for teaching, there needs to be new teaching, or there at least needs to be progress towards the patient learning, or there needs to be a new caregiver, or there needs to be something. You can't just continue to teach for episode after episode after episode, certification period after certification period, for the same things. Some things you might be teaching on: assessment and management of acute or chronic conditions, blood glucose monitoring and insulin adjustment, dietary management and foot care, monitoring for the stroke recovery process and teaching on that, therapy for ADL retraining or swallowing cognition, teaching caregivers about seizure precautions or Parkinson's care. All of these are examples of teaching. Another example would be post-surgical care. If they have drains, the care and the removal of those drains, monitoring for signs of infection or complications, therapy for gait training, joint mobility, adaptive equipment instruction, any of those things surrounding surgical, post-surgical care. Other examples, nutrition and hydration support, skilled oversight of those tube feedings, IV hydration or TPN could be included in that. Again, these are not all inclusive, but there's some examples. Also for pain management, would be considered a skilled service, assessment of those pain levels in response to the interventions, teaching the use of pain pumps, non-pharmacological strategies. Again, you can't do this forever, but you can do this for a while. When you're talking about how you document skilled service, you want to make sure that your clinical notes document the history and physical exam pertinent to the visit and the response or changes in behavior to previously administered services. So what did you do on the last visit or the last few visits? If it's teaching especially, what did you teach? Did they retain it? What do you need to reteach? What is the new teaching? You want to make sure that you're documenting that well. Skilled services performed at the visit and what's the response? And you don't want to use vague phrases like patient tolerated well or tolerated treatment well. You want to avoid descriptions of skilled care like instructed on medication management. What did you do? What exactly did you teach on? Instructed on pain management. No, that won't do it either. It can't be those vague phrases like that. You need to say what you taught exactly, or continue with plan of care. None of those are good things to have in your documentation. If you're seeing that in your documentation, you need to be having your clinicians document specifically what they taught. A plan for the next visit based on the prior results. What did you teach them? What are you going to do the next visit? Or if it's a skill, what's your plan for your next visit? A detailed rationale that explains the need for that skilled service in light of the patient's overall medical condition and experiences. Who are their caregivers? What has happened since the last visit? What has happened since you've taught them? What did they retain? What did they not retain? The complexity of the services to be performed. Any pertinent characteristics of the beneficiary or home. So if there's circumstances that make it so that you need to continue, or you need to do additional teaching or additional skilled services, you need to describe that. It needs to be well documented in the clinical note. The documentation should clearly show why that service can't be safely performed by a non-skilled person. Next slide. So in summary, for skilled services, if all other eligibility and coverage requirements under the home health benefit are met, skilled nursing services are covered when an individualized assessment of the patient's clinical condition demonstrates that the specialized judgment, knowledge, and skills of a registered nurse, or when provided by regulation a LVN or LPN, skilled care are necessary. Skilled nursing services are covered where such skilled nursing services are necessary to maintain the patient's current condition or prevent or slow further deterioration, so long as the beneficiary requires skilled care for the services to be safely and effectively provided. It's a lot of words there to say you need to justify your skilled care and make sure that it's documented really well whenever you're justifying the skilled care. All right, next slide. I think we're at the end.
Yes, thank you, Lisa. Folks, if you have any questions for Lisa, go ahead and type them into the questions box or the chat box, and we will try to get to as many as we can before we wrap up today. That was great, Lisa. Thank you so much. I think that refresher on what exactly is skilled care and how to, document appropriately for it is really going to be a helpful thing for our listeners. All right, so now we would like to move on to our scenario spotlight. And this is a section where we share scenarios and potential responses for you. Last month, we had a scenario about an 88-year-old patient who was admitted to home health following a long hospitalization for bowel obstruction. And we asked you to consider how you would respond to the OASIS eating items. And the OASIS responses that our expert suggested for this patient, for M1870, they suggested 2, unable to feed self. And for GG1030A, the correct scoring they suggested was 2, substantial maximal assistance. But that M1870 answer, Lisa, you and I went back and forth. We had quite the email thread going on about that one. Could you share a little bit about our discussion on that item?
We did. So, when you're looking at M1870, so the patient had to have not only the meat cut up into small bites and, so the meal not prepared, the meal set up. Not only did they have to have that, but they also were unable to feed themselves the entire meal. So the question, I think the reason we all struggle so much with this is because when you're answering the 01 answers, the patient was unable to feed themselves, or the patient needed setup or cleanup assistance, or they needed assistance with the feeding of the meal, or they needed a liquid or pureed diet. And those were all ors. So this patient needed more than one of those. So 02 on this one would be the most appropriate answer.
Thanks so much, Lisa. Yeah, that question ended up being giving us a workout too. So that was fun to work through. All right, and we have a new scenario for August, and this scenario takes a look at a patient who returns to service after a night in the hospital for a diagnostic test, and we are asking how you would handle your OASIS requirements for that patient and what the best selection would be, whether you're discharging or not, which versions of the OASIS should you be responding to. So you'll see the question and the potential answers in your handouts. And if you are listening to a podcast episode of this show, you'll find the handouts on the OC website, along with the recording under resources free webinars. So you can refer to this and choose an answer and join us next month to see what our expert chose. And we did get a question in And let's see, it's not related necessarily to the OASIS Q&A topic, but I wondered, Lisa, if you might have an answer for this listener. They are wondering if the patient is moving from a Medicare Advantage plan to traditional Medicare due to payer change, how does that impact the face-to-face requirement? Is that something you can answer on the fly, or is that something that maybe takes a little more research for us to respond to?
So for face-to-face, for a Medicare Advantage, you need to know, does that Medicare Advantage require a new face-to-face when you start them on service? They should honestly not, because you're actually not required to do a new start of care. You're actually only required to update the payer on the next OASIS assessment time point. So you wouldn't have to have a face-to-face. I'll be honest with you. Most of the agencies that I work with, they do, and it's partially because of EMR, partially because their policy, whatever it is, they generally do a new start of care. And when they do that new start of care, they get a new face-to-face. Now, again, when you're going to Medicare Advantage, it's not required. So you would not have to do a new face-to-face in that situation, because like I say, you're just going to update the payer at the next OASIS time point.
Okay, so what if, is it the same if you're going from a Medicare Advantage to traditional Medicare?
No, it's not. Medicare Advantage, traditional Medicare requires that new start of care, and you would absolutely need a new face-to-face with that one.
Okay, so it depends which way you're making that transition.
Yeah.
What the right thing to do is. Okay, great. Thanks so much, Lisa. All right, and next up, we would just like to take a moment to thank our sponsor for this month's program, Decision Health's Home Health Coding Center. Boost productivity, avoid costly errors, and save up to 60% compared to traditional print resources with the Home Health Coding Center, the leading online solution for home health ICD-10 coding and OASIS review. Start your 14-day trial for free at decisionhealth.com/coding and discover this unique resource designed by home health experts. And now we're on to the part of the call when I share what's new with AHC, sharing updates from the Association of Home Care Coding and Compliance. And this month, I want to share some updates from the AHC Advisory Board. We have 3 members stepping down as their terms have ended, and they are Claudia Baker, Elise Christensen, and Nanette Minton. We're so grateful for all the help that these folks gave the association and for our members. They were guests on many episodes of AHC Talk over the last 3 years, so I'm sure you're familiar with their voices and all the great information they shared over the years, and we will certainly miss them and hope to have them back with us again soon on one of these calls. And we have 3 new board members with terms beginning this month: Janan Griffin, Celeste Miller, and Lisa Salmon-Holman. And we're looking forward to working with them and hope that we will have them on a future episode of AHC Talk coming up soon. So that's the latest from the Association of Home Care Coding and Compliance. We hope you enjoyed this episode of AHC Talk. Thanks again, Lisa, for all the great information you shared today. And thanks to all of you for tuning in. We hope you'll join us again for our September call, when we'll be taking a look at the fiscal year 2026 ICD-10 coding updates. And in the meantime, if you'd like to re-listen to this episode or a previous one on the go, you can find AHC Talk on your favorite podcast app. Or you can also listen to the recording and access the handouts on the AHC website at ahc.decisionhealth.com. And if you have any suggestions for future guests, topics, or ideas about the format of the show, please send me an email at jan.milliman@decisionhealth.com. Thanks again for listening. We'll see you next month. Take care.